I want to discuss four particular topics in this talk. Number one is to analyze the problem of drug-drug interactions. Then specifically, secondly, to look at integrase inhibitors, their similarities and their differences. Then to focus on integrase inhibitors and TB therapy. And finally, integrase inhibitors and co-infection with HCV. So they're the four topics. So number one is the problem of drug-drug interactions. And that is that when you look at the increasing numbers of patients on antiretroviral therapies, there will be within that population an aging population. We know that is something which is from the demographics. We have an aging population. There is always the issue of different prescribers, of knowing the co-medications that a patient is on. The fact that patients have online access to drugs, can get drugs from other sources, maybe over the counter from the pharmacist. The recreational drug use that we see in many patients. And this all adds up to polypharmacy. And given that we have relatively few formal drug-drug interaction studies, so in development of a drug, a new medicine, maybe 20 formal drug-drug interaction studies will be performed, but we have 1,000 plus co-meds. And so we then have to try to understand from the information we have the likelihood of a drug-drug interaction. So clearly we need help. And Liverpool is only known for two things. One is a soccer team with many good Brazilians, and we have a really wonderful Brazilian team in Liverpool. And also the Beatles, and the Beatles, the musicians, cried help, and we tried to give some help. So, the questions we have to address is, does the antiretroviral drug affect the exposure, the amount of drug in the body of another co-med? Or is it a co-med that will affect the antiretroviral drug? And if you answer yes to those questions, then what is the magnitude of the change which occurs? And does that change have any clinical significance? Not every change is clinically significant. We need to focus on those that are clinically significant. And if it's clinically significant, what are you going to do about the drug-drug interaction, the management strategy? So we use two terms from a pharmacology perspective. One is the term perpetrator. Is the drug a perpetrator of an interaction, or is it the victim of an interaction? So you'll see those two terms in the talk. Now, you can summarize all the antiretrovirals as though with those drugs with a high potential or a highest potential of an interaction, that is the boosted regimens, boosted protease inhibitors, and the integrase inhibitor, which is boosted, DOLUTEGRAVIR, plus efavirenz. So with efavirenz, that is doing something different to the boosting. It is an enzyme inducer, a perpetrator of induction. The low potential interaction drugs are raltegravir, dolutegravir, and bictegravir. They're not all exactly the same, but they have the lowest potential, as do the nucleoside reverse transcriptase inhibitors. Now, please don't think they have no interactions. They just have a much lower potential for interaction than do boosted regimens and efavirenz. So that is a demarcation for the antiretrovirals. Just one slide to illustrate where boosted regimens as perpetrators of interactions can have an impact on many therapeutic classes of drugs. We don't have to read this slide other than get the message that be it corticosteroids or antidepressants or chemotherapy or anticoagulants, particularly the new anti-oral coagulants, calcium channel antagonists, statins, many therapeutic classes Within those classes, drugs can be influenced by boosted regimens, and you have clinically significant interactions whereby something will need to be done, either a drug change or a dosage change or an increased monitoring of the patients on those regimens. So that is something very important for boosted regimens. So we have to think about that. Now, we do have help, and we all need help. And so the help is from resources that will try to collate the information and help in the management process. So in Liverpool, we've produced our interaction data, but that is not the only source. So from Toronto, there is also very good information from a website and apps where you can search for the kind of information that will help us in management of our patients. And so we do need help to be able to really go forward in this area of drug-drug interactions. So as we look at the integrase inhibitors with a low potential apart from elvitegravir cobicistat, then let's look at some of the similarities and differences. We know that doses are different for the integrase inhibitors. So you can just see the clinical dose and you will know that the clinical doses are different. But also the DDI potential of the different integrase inhibitors, the lowest potential is raltegravir, slightly greater for dolutegravir and bictegravir, the highest for elvitegravir. And this is to do with the way that the liver handles the drugs, that if it's a CYP3A metabolic route, it's a key enzyme, then for elvitegravir, you just don't get enough, you have to boost it. But bictegravir has also got some CYP3A in its metabolism, equal with another enzyme called UGT1A1. So it's really to do with how the body and the liver handles the drug as to the potential for an interaction for the integrase inhibitors. Now, there are some important interactions, and the ones that many people have focused on for integrase inhibitors are cations, metformin, and enzyme inducers as exemplified particularly by rifampicin. So the cation interaction is one that I just want to mention, where the integrase inhibitor is a victim of an interaction. With metformin, the integrase inhibitor, particularly dolutegravir, is a perpetrator, causes an interaction. And then rifampicin, we go back to the victim. So these are just selected DDIs for these particular integrase inhibitors. And we'll deal with those in just a little bit more detail. The importance of knowing why it is that a cation can interfere with an integrase goes back to the mechanism of action, which Charles began our session with this morning. Because at the heart of an integrase inhibitor mechanism is that it binds to magnesium in the integrase. So the reason that an integrase inhibitor works is because it binds to integrase via magnesium. So that if you have a cation in the body, then the integrase inhibitor will bind to the cation. And so you look for an interaction with antacids, so a magnesium-containing antacid. And you can see here, the one example is with dolutegravir. If you give dolutegravir alone, then dolutegravir, you get an exposure. This is the blood concentration of dolutegravir. If you give it at the same time as the antacid, then the exposure goes down by 74%. So clearly, that is going to be an adverse interaction. So what do we do about it? Well, we have to look at the recommendations. And this is where it can get quite confusing. Because with raltegravir and antacids, because of the magnitude of interaction, it is not recommended to give raltegravir and an antacid. For dolutegravir, separate well so that the dolutegravir can be absorbed, separate well 2 hours before or 6 hours after the antacid. For elvitegravir, it says separate by at least 4 hours. For bictegravir, take under fasting conditions 2 hours before. So you can see that it's very confusing that you have similar drugs and the interaction is, it is slightly different for the different integrase inhibitors, but the label recommendations, I think, can be quite confusing. The really important thing, raltegravir is not recommended. For the others, you need to separate out the integrase inhibitor so that it can be absorbed before an antacid is actually given. And that is what those recommendations are saying. It gets even more confusing when you look at calcium, because many patients may be taking a calcium supplement or a calcium-containing antacid. And maybe the reason, if you are seeing failure, is that patients have low exposure because they're taking some over-the-counter medications, which is affecting the dolutegravir or the integrase inhibitor. So here you can see the recommendations for calcium, which are actually different. Particularly bictegravir is a little confusing because previously it says fasted, now it says can be taken together without regard to food. Now, I do think we need some better way to look at the complexity in the labels, and this is the European label, by the way, and the US label can be even different from the European label. So it is a confusing area, made even more confusing by the fact that I don't know what it's like in Brazil, but there are so many different preparations containing calcium. You can have calcium in high dose as a supplement, or you can have calcium in a lower dose in a multivitamin preparation. Or what about a glass of milk contains calcium? So all of these differences, I think, are really confusing, and we need, and I'm trying to work with the regulatory authorities at the moment to get a better way of being able to give this information around the different preparations. So it is very confusing, but important, and I think in terms of patients who may fail, we have to look at this sort of area as to what they're actually taking. With metformin, it's slightly different, because the metformin interaction is that it was seen initially with dolutegravir, because dolutegravir and metformin can interact in the kidney, the proximal tubule. So this is supposed to be a representation of the proximal tubule, and the metformin is using a transport protein, a little shuttle protein, to get it across the proximal tubule into the urinary space. And dolutegravir inhibits the metformin, which means that you see an increase in the exposure of metformin. If it was with the once daily dolutegravir, about 80%, twice daily, 150%. So we have to think on an individual patient basis. And one thing we ought to note with metformin is that if you have any degree of renal impairment, then metformin dosage adjustment is also related to the degree of impairment. So you can see here that the recommended dose gradually decreases as your renal function decreases. So if you combine the fact that a patient might be on an integrase inhibitor with anti-diabetic medication, and if there's any degree of declining renal function, then that compounds the interaction as well. How important is it? This is always difficult to get really good real-world data. Now, this one study of a retrospective case of 19 patients on dolutegravir and metformin shows us 3 patients with GI distress, 3 patients with hypoglycemic symptoms leading to metformin change. But it was only in 2 patients with a change, 2 patients with discontinuation, no lactic acidosis. So it's not in every patient, it's an individual patient that you have to understand the patient case as we look at this particular interaction. There is no interaction with raltegravir and metformin. With elvitegravir and bictegravir, there is no study data as such. With elvitegravir, it's caution. With bictegravir, it is about half of the interaction that we see with dolutegravir and is probably much less of a concern, but nevertheless, it depends on your patient circumstances. Which brings me to the TB therapy. Now, let's remember that rifampicin as a mainline TB drug is a very potent inducer of enzymes and transport proteins, which is the way the body is getting a drug in and getting it out. So for raltegravir, there has been 2 lines of thinking that you don't need to do anything as far as the BD dosing, 400 milligrams BD. Other people say double the dose to 800 milligrams BD. But remember that the RAL exposure is declining. With dolutegravir, you get a 50% decrease in exposure. So it's a doubling of the dose of dolutegravir in the absence of integrase resistance. But it's not a doubling if you were using Triamec because you have to add another dolutegravir 50 milligram tablet. Elvitegravir is contraindicated. Bictegravir is also contraindicated because of the magnitude of the interaction, not only with bictegravir, but with the TAF that is present in the single tablet regimen. Now, the data with dolutegravir from the INSPIRING study, which has been presented throughout 2018, is that this was the study in patients who were on the quadruple regimen for TB, where dolutegravir dose was doubled, and then after treatment it went back to monotherapy, back to the single dolutegravir, and then you had also a comparison arm with efavirenz, and you can see the data with the efavirenz arm being much slower in terms of the response versus your classical integrase. So you have good data giving dolutegravir BD with rifampicin, and the pharmacology is also shown in the blood levels of dolutegravir in the presence of rifampicin BD. However, there's been a lot of discussion in the last few months in leading articles about, with the rollout of dolutegravir, will giving an extra dolutegravir be something that can be done on a widespread scale? So the additional dose of dolutegravir in this review was stated to be difficult, maybe, to implement in high-burden settings where nurses often prescribe making such a complex regimen of adding another dolutegravir 12 hours afterwards, and the whole issue of stock out and the other problems of adherence. So that was raised, and then recently in a Viewpoint article, the article on dolutegravir for first-line antiretroviral therapy, adjusting the dolutegravir dose might be challenging in public sector programs, negating the benefits of a once-daily regimen. So there is some degree of concern about the approach, which is clearly necessary. And so some people have said, well, can we actually double the dose of dolutegravir, not by giving it BD, but giving it once daily as 100 milligrams? So doubling the dose, but a once daily doubling. And data from a recent study by Marta Bafito and her colleagues, which was presented at a meeting in the States just a couple of months ago, really gave the answer to that to be no. Because the exposure of the dolutegravir, even if you doubled it to 100 milligrams, comparing the C trough value, was 75% down. There was a substantial reduction in dolutegravir of 75%, when co-administered with rifampicin. So that is giving 100 milligrams of dolutegravir plus rifampicin, and you still see this magnitude of decrease of the dolutegravir exposure. So I think we have a little bit more work to do to really understand the best way forward. Remember that bictegravir is contraindicated with rifampicin because a study was done with bictegravir BD plus rifampicin, and it's shown here. And even giving it BD, you did not get the exposure that you would want without rifampicin. So bictegravir without rifampicin is shown in the blue. With rifampicin, giving bictegravir BD, you're seeing the orange color, and the exposure is less. And also TAF in bictegravir is declining by a large amount as well. So this brings me finally to integrase inhibitors and HCV therapy. Now clearly HIV-HCV co-infection is really an important topic. And we need to recognize that there are many clinically significant drug-drug interactions that can occur between our antiretroviral and our DAA regimen. So there may be the need to change the antiretroviral regimen before prescribing a DAA for HCV. If that's not possible, then is there a DAA that you have access to? And I realize the limitations of DAAs in many territories. Then we have to work around the drug-drug interactions. That is important. Just one simple slide about the characteristics of HCV drugs, and it is the protease inhibitors listed here which have the highest potential for interaction, and the NS5A inhibitors have a low to moderate potential for interaction. So you can see the different drugs that are here. So we have to bear in mind the interactions that can take place. And again, we've tried to produce resources with a hepatitis website for trying to take us through the complexities of these issues. There are also, don't go through these, it is simply to say there are charts in the US ASLD IDS guidelines which you can go to, which gives you greens and reds. Greens mean these are the drugs you can give. The red table means these are the drugs you can't give, with different DAAs and the HIV drugs. Similarly, in the European guidelines, we have charts. It's the same color coordination. Green means go, red means stop. The yellow or amber means caution. And you don't need to go through it there, but what you have is all the different drugs listed for the antiretrovirals, the different DAA regimens. Can you give? Can't you give? So we need to know what we can give and what we can't give. So I want to finish with a case. A 49-year-old MSM diagnosed with HIV and HCV. The HIV therapy the patient is on is darunavir plus FTC TDF. You can see the CD4 count, viral load is suppressed. This patient is suppressed, but diagnosed with HCV, treatment is now necessary for the patient for HCV. Genotype 1A, you can see the HCV PCR, the FibroScan, F4, previously failing soft-PEG-RIBA in 2014. So, if we look at this patient's co-medications, at the time of considering the DAA therapy, the patient is on amlodipine, metformin, atorvastatin, and omeprazole. Now, the HIV provider has already assessed the DDIs between the antiretroviral darunavir regimen and the co-meds, so that the patient, although if you look it up, you find this amber yellow color, the amlodipine dose is 5 milligrams, so it's a low dose of amlodipine, which is what you would need with a ritonavir regimen. And the low dose of atorvastatin, the maximum you would want, is probably 20 milligrams. The patient is on 20 milligrams. So at this stage, the interactions have been taken into account. But now we want to know what DAA regimen would be compatible with darunavir-ritonavir. Is there a DAA regimen that you have available? Now, so you look down and you see the charts that you can get, and these show the antiretrovirals, or some of the antiretrovirals from two classes, and sofosbuvir, decladisvir, the ABV3D regimen, GP, and Sofel. Now, I know that not all those HCV drugs would be available, but you can already see that with the NNRTIs, there's a lot of contraindications. But with the NRTIs, there is only one AMBA, which is around sofosbuvir, valparasvir, and tenofovir. When we go to the protease inhibitors, it becomes a little messy, because protease inhibitors do not like protease inhibitors. So if you've got a patient on an HIV protease inhibitor, it doesn't like an HCV protease inhibitor because of interactions and the magnitude of what is going to take place. So given you've got all this, and it's really hard to take it all in, what are we going to do? Well, we can summarize. Let's say you have the ABV3D available, and you have decladisvir available. Now, the ABV3D should not be used in patients on those listed drugs there. And also in the US guidelines, it says darunavir-cobicistat. In the US, it also says darunavir-ritonavir. The European label does not actually say that. It's not recommended in the US. It's cautionary as far as the European label is concerned. Decladisvir, well, you have to look at some dose modifications. 60 milligrams, dose reduced to 30, or go up to 90. So something needs to be done in many cases. What are we going to do with our patient on darunavir-ritonavir? Because we want to actually think about giving the 3D regimen. If we're going to give 3D, why don't we switch the antiretroviral, if it's possible, to DOLUTEGRAVIR, because that then eliminates the ritonavir issue. But then you think, actually, my patient's on metformin. So I'm going to switch to DOLUTEGRAVIR, but the patient's on metformin. But there are no interactions between the 3D and DOLUTEGRAVIR, but we do need to check some of the other interactions that take place. And then we have to go in and say, we're using the 3D regimen, a DOLUTEGRAVIR HIV regimen, so we need to remember that the patient's on low-dose amlodipine, which is great, but I can't use atorvastatin because the patient now is taking a 3D regimen, which is contraindicated with atorvastatin. So could you stop the statin for the 12 weeks the patient is receiving HCV, or change the statin to one that doesn't interact, and there are a number of statins which will not interact. So it's really thinking through logically the stages that will need to be gone through if you're going to manage a complex patient like that. So finally, 2 slides illustrating that we need to understand what are people interested in worldwide. This is our search in our database. So worldwide, the top search last year of interactions in our HIV chart was for atorvastatin, followed by omeprazole, followed by metformin, followed by rosuvastatin. That's what people were interested in. In Brazil, the top search was omeprazole. So the most searched for drug was omeprazole with antiretrovirals, followed by, interestingly, epilepsy drugs, valproate, clonazepam, carbamazepine, which I thought was quite interesting, which is different from many regions, but that was the highest search. So key points, we have to remember the DDI potential, review co-meds, but please, we're all going to need resources in order to help us manage DDIs. Thanks very much.